Hello, everyone, and let's talk a little bit about differential diagnosis of anemia. So, as you all know, anemia occurs when red blood cell or hemoglobin levels fall below normal range. And what is the normal range of hemoglobin in adult? Is 130 to 180 gram per liter for men and 122 to 160 gram per liter for non-pregnant women. So the common clinical the anemia is a common clinical problem and has multiple underlying causes. We're going to explore shortly. Proper diagnosis require a systematic, thoughtful evaluation, and always really important to be systematic and organized doctors. So we will start by just symptoms of anemia, which is fatigue, weakness, dizziness, pallor, shortness of breath, and headache. And it could also cause like anemic heart failure. So will be like having, they can have chest pain on exertion, they can have shortness of breath in exertions. Always be aware of heart failure as a red flag in any person with anemia. Anemia also can cause cardiomyopathy. So be also mindful with cardiac problem in anemic patients. And heart failure as well can cause anemia. So always don't forget about anemia, and especially high output heart failure, because if the patient have low hemoglobin, so the heart will work very hard to pump the blood, which is going to make high output heart failure. And we also need to look for detailed history to find out about the exact cause of anemia. And we need to elaborate the presenting symptoms and try to address all the differential in a very professional, systematic way. And then we'll go to the examinations and we look for bladder jaundice and organomegaly and any signs of bleeding, because anemia could be due to bleeding, or also hemolytic anemia is very important cause of anemia. And of course, we need to do our lab investigations, especially CBC, peripheral blood smears, ion studies, and B12 and folate levels. So anemia classifications, we can classify anemia according to the MCV, mean corpuscular volume. The normal range of MCV is 80 to 100 FL, which we call it normocytic anemia. And if the MCV are more than 100 FL, will be macrocytic anemia, and if less than 80 FL will be microcytic anemia. And we're going to speak about each of these type of anemia in a little bit of details. So microcytic anemia, it could be due to iron deficiency anemia. And iron deficiency could happen due to many reasons, either due to blood loss or due to increased demand during pregnancy or poor dietary intakes, and also could be due to malabsorptions. So you need to bear in mind all these causes, and you need to address in your history of presenting illness. And anemia also could be due to inherited diseases such as thalassemia or sideroblastic anemia. And microcytic anemia also could be due to chronic disease. So this is the most common causes of microcytic anemia is iron deficiency anemia, thalassemia, sideroblastic anemia, and chronic disease. So chronic disease, this happens because the inflammatory process block of iron utilizations. Normocytic anemia. In fact, before I talk about normocytic anemia, let me just give you more details about microcytic anemia, because it's just really important. I need, and it's very common in exams and comes everywhere. So if you just allow me to speak a little bit about that. 1 second. So iron deficiency anemia, as I said, the etiology could be due to inadequate dietary iron intake or impaired ion absorptions, such as celiac disease or gastric surgery. So we'll ask about any surgical procedure or surgical operation in the past. And increase iron loss because of bleeding, as I mentioned, or because of even using of NSAID. So in the drug history, we need to ask if she's using any over-the-counter medication, such as ibuprofen. So it could be the cause of iron loss due to bleeding, can cause gastritis. And also increase iron requirement in young children due to growth or pregnancy and lactations. So so to evaluate iron deficiency anemia, in the physical examinations, we can find glossitis, angular stomatitis, and nail changes such as thinning or flattening or spooning of the nail, which we call it coloniclia. So investigation wise, like it's really important to check the hemoglobin level and the MCV to decide is it microcytic, normocytic, or macrocytic. And as I mentioned in our session today, when we do iron study, in iron deficiency anemia, we find the iron is low and ferritin is low, and total iron binding capacity is high. So iron deficiency anemia, uh, iron and ferritin are low, but total iron binding capacity is high. Uh, by contrast, anemia of chronic disease, the ferritin will be high, so the opposite, and the iron will be low, same like iron deficiency anemia. So both of them iron is low, and the total iron binding capacity will be low. So anemia of chronic disease will find high ferritin and low total iron binding capacity. Let's move to the normocytic anemia. So the causes is acute blood loss could be due to trauma, surgery, or GIT hemorrhage, or it could be due to hemolytic anemia, such as autoimmune disease, sickle cell anemia, and hereditary spherocytosis, and chronic disease such as kidney disease, liver disease, bone marrow infiltrations, and aplastic anemia. So as you can see, like to have a normocytic anemia, like with normal uh, red blood cell shape, so the cause could be like trauma, surgery, and hemorrhage. So as you can imagine, we don't have any problem with the synthesis of the hemoglobin or the shape of the hemoglobin. It's all about the loss of blood or autoimmune disease that can destruct, cause destructions to the RBCs, but still the remaining RBC will be normal shape. And also other type of hemolytic anemia could cause destruction to the RBCs without changing the shape. However, in the sickle cell anemia, as we know, and spherocytosis, we have different shape as well, but the MCV will still remain normal. And also, like anemia of chronic disease is going to affect the iron utilizations, but it's not going to affect the MCV size. So that's why all these causing us normocytic anemia. And the last type is macrocytic anemia, which it could be due to vitamin B12 deficiency, folate deficiency, or other causes. So, so I'm trying just to minimize the Zoom session. So for macrocytic anemia, for vitamin B12 deficiency, such as in pernicious anemia and malabsorptions. They are the common cause of vitamin B12 deficiency, so pernicious anemia and malabsorptions. Patients may show neurological symptoms alongside anemia because of B12 affect our nervous system as well, so they can have neurological symptoms alongside the anemia. Folate deficiency is seen in poor nutrition and pregnancy due to increased demand, as I said, and alcohol misuse. Blood tests show megaloblastic changes and hypersegmented neutrophils. And other causes like myelodysplastic syndromes affect the bone marrow productions, and drugs and toxin exposure, especially chemotherapy, can cause macrocytosis or macrocytic anemia. So to repeat again, macrocytic anemia could be due to vitamin B12 deficiency, can happen as a result of pernicious anemia or malabsorptions, or folate deficiency, which could be due to poor nutrition, pregnancy, and alcohol misuse. And other causes, such as myelodysplastic syndromes, can affect bone marrow productions, and drugs and toxin can also cause macrocytic anemia. Special and uncommon causes of anemia, such as chronic infections, hepatitis, malaria, HIV, cytomegalovirus, parvovirus B19, and microangiopathic disorders such as hemolytic uremic syndrome, DIC, TTP, toxin and metabolic lead toxicity, hypothyroidism, glucose 6-phosphate dehydrogenase deficiency, and malignancy such as leukemia and bone marrow infiltrations. So any patient with anemia, we need to rule out cancer. So we'll ask also the cancer symptoms such as night sweating, rising temperature, and weight loss. So just to summarize, any patient presenting with fatigability, or we find in the lab this patient has anemia, we need first to decide, is it microcytic, normocytic, or macrocytic? And then after that, as I discussed, different causes for each subtypes, you need to put in your mind which could be the possible causes, and you need to do the lab according to further blood testing according to your differential, and don't forget to evaluate chronic diseases and ask the drug history in details as we do in any case, and don't forget about inherited conditions because it play major roles in anemia, such as thalassemia, sideroblastic anemia, and like sickle cell disease, lots of glucose 6-phosphate dehydrogenase deficiency. So lots of inherited diseases can cause anemia. And further testing depends on your initial evaluation. So you may end up doing bone marrow biopsy or do genetic testing if indicated. Thank you so much. If you have any questions, please.